Okay, so the 6 easy steps to ABG analysis are, once again, it's first of all to look at the pH, and when we're looking at the pH, what we're going to try to do here is to evaluate it to find out if it's normal, acidotic, or alkalotic. So we're not looking at it and saying it's high or low. Again, we're saying it's normal, acidotic, or alkalotic. Step number 2 is to look at the CO2. Again, assessing whether it's normal, acidotic, or alkalotic. Step 3 is to look at the bicarb, and we're going to determine if it's normal, acidotic, or alkalotic. Now in step 4, we're going to match the pH with either the CO2 or the bicarb. So what matches the pH is the primary imbalance. And then in step 5, we look for the value that goes opposite direction of the pH. So if the pH is acidotic, we're looking for the thing that's alkalotic. That's what we mean by opposite, not up or down. That's compensation. Lastly, in step 6, we're going to look at O2 and O2 saturation. So let's take a look at the rest of the examples that we had. Number 4, we have a pH of 7.49. Okay, so here again is the normal values. pH 7.49 is alkalotic, right? Okay, the CO2 of 40 is normal. And then our bicarb of 29 is alkalotic. Okay, so which one matches the pH? The bicarb, therefore we have a metabolic alkalosis, right? Okay, now in step 5 we looked at the CO2. Did the CO2 go the opposite direction? Is the CO2 acidotic? No, it's normal. So there's no compensation. Okay, so we simply have an uncompensated metabolic alkalosis. You with me so far? PO2 and the O2 saturation are? The PO2 is a little low, right? The O2 saturation is okay, but the PO2 is a little low. Now, whenever one value is abnormal, so if one of these two values is abnormal, one of the two values is low, we still call it hypoxemia. So we're going to call this hypoxemia despite the fact that the saturation is good. But we're going to call it hypoxemia because the PO2 is low. Okay, now what would cause a patient to have a metabolic alkalosis? Is patients losing acid from their body? Vomiting. Okay, think about where we've got a lot of acid. We've got a lot of acid in the stomach. The patient's vomiting, losing acid from the stomach, and the patient develops a metabolic alkalosis. Now, a metabolic acidosis will occur when a patient has diarrhea. Okay, so it's the opposite problem that occurs. So another way to remember this is if the fluid is coming up, the pH is going up. If the fluid's going down, the pH is going down. It's kind of a gross way to remember it, huh? It works, right? Okay, so our treatment then is going to be, let's stop the vomiting, give an antiemetic, or if the patient has an NG tube in and we're pulling off all this fluid, we can't give them back the fluid, right? So we're going to have to do something else to give them back acid. And how we're going to do that is we're going to give the patient IV fluids. When you give your patient normal saline or lactated ringers and they're in an alkalotic state, what will happen is that the body's going to hang on to the chloride. Dump off the sodium, hang on to the chloride. The function of chloride in the body is to help balance pH. So that extra chloride is going to help balance pH. So the short story is IV fluids will help to make your patient more acidotic. It'll help if your patient has a metabolic alkalosis. Number 5, we have a pH 7.10, and that is? Acidotic. CO2 of 25 is? Alkalotic. Okay, how about our bicarb of 7? Acidotic. So which one matches the pH? The bicarb. Therefore, we have a metabolic acidosis. Does the CO2 go the opposite direction? Yes, it's alkalotic. Right? So that means we have compensation, and we're going to call it partial compensation because it did not get the pH back to normal. See, the whole goal of compensation was to get the pH back to the normal range. And we do have compensation. You see that evidenced by the fact that the CO2 is going the opposite direction, but we did not get back to the normal range. Therefore, it's what we would call partial compensation. Okay, now one thing to keep in mind about compensation, when you're talking about compensation, don't talk about compensation from the system it's coming from. In other words, We would not say in this example that the patient has a metabolic acidosis with respiratory compensation. See, that's redundant. Where else is the compensation going to come from? Right? There's only two systems. It's redundant and it's confusing because when you're in a code situation and somebody yells out metabolic acidosis with respiratory compensation, you're sitting there going, respiratory what? Right? And you start thinking, you see how it gets confusing? Right? So let's just say partially compensated. We know it's coming from the respiratory system. It's the only system that can compensate for a metabolic problem. Okay? Now okay, we didn't look at the PO2 and the O2 saturation. They are normal. Okay, so this patient here has a pretty severe metabolic acidosis. Now, as I mentioned, diarrhea can cause metabolic acidosis. But what else can cause metabolic acidosis? How about shock?
Bleeding, you're talking about things like bleeding from every orifice in their body.
Okay, yeah, so somebody who's in shock or bleeding or trauma, things like that can cause. How about sepsis? That can cause metabolic acidosis, right? How about DKA? Okay, diabetic ketoacidosis. All right, so those are all situations that can cause a patient to have a metabolic acidosis. Now, this metabolic acidosis here is pretty bad. Look how low that bicarb is. It's 7. Because that's pretty bad. So this is a pretty severe metabolic acidosis, probably not caused by renal failure or diarrhea or something like that. Probably more severe, this is probably shock or maybe DKA. Now, is it likely that your patient in shock is going to oxygenate this well? Probably not, right? Okay, so this is probably a patient who has DKA. Now, all we would need to do to verify that is to get a blood glucose. And then that would get us on the right track as to what's happening, right? So this is probably DKA. What is our treatment for DKA? Insulin. Okay, you notice I didn't say what is our treatment for a metabolic acidosis because what we do is we treat the problem, which is the DKA, not the metabolic acidosis. By treating the DKA, it will correct the metabolic acidosis. So instead of giving this patient bicarb, we want to give this patient insulin to correct the problem, which will make the acidosis go away. Does that make sense? Okay, one more. We have a pH of 7. Okay, go ahead.
What about this? How did you figure out that that was DKA?
Because they're oxygenating, but the bicarb is there.
So that made it, you know that was it. Okay.
Exactly. Because they're oxygenating well, but they're really severely metabolic acidosis, so probably something like DKA. Now, you'd have to get a glucose to find that out. Okay, we can't just tell by the blood gas. But my guess would be this is probably more likely to be DKA than it is likely to be shock, based on the oxygenation. Okay, number 6, we have a pH of 7.42, and that is? Normal. CO2 of 18 is? Alkalonic, and the bicarb of 11 is? Acidotic. Okay, now we have a normal pH. It's compensated, right? We know that because there's problems here. Because there is an alkalonic CO2 and an acidotic bicarb. So we know that there is a acid-base abnormality here that we need to find out about. So how do we figure out which one it is? Go back to the pH and ask yourself, what side of 7.4 does it lie on? The alkalotic side. Right? Now you can match it up. What other value is alkalotic? The CO2. So this is a respiratory alkalosis with what kind of compensation? Full or complete compensation. PO2 and the O2 saturation. Saturation's okay, but what about that PO2? What does that tell you? Patient's on supplemental oxygen, too much supplemental oxygen, right? Okay, so now what's this patient doing? The patient has a CO2 of 18, so what are they doing? Too fast, right? And blowing off that extra CO2? So we need to slow this breathing down. In fact, this patient has been hyperventilating for so long that they have metabolic compensation for that hyperventilation and that respiratory alkalosis. So that's kind of a chronic hyperventilation that this patient has going on.